I have today, I think, 6 of my 12 new consults were all IV heroin users with abscesses. It's sad, and I want to help every last one of these people. I want to help everybody. And when they come to the hospital, that's our opportunity. So that's sort of where I live. So getting back to the HCAP scores, what happens? The administrator at another hospital called me in recently and said, "Doc, this patient signed out AMA. Tell me again why this is okay. Why is this a good thing?" Because, we all hate in terms of looking at satisfaction if people are just going to leave because they're pissed off. Like, it's okay because they don't want the help that we're offering them. They'll go someplace else, and so when they come here and they don't like me, I tell them where else not to go because I'm on staff at 2 other local hospitals. So take the bus all the way west is what I tell them, or up north. So they'll be back. When I first started doing this, our CFO called me one day, and I thought, oh no, I'm really in big trouble this time. Well, it was a prisoner who had a very unusual hemophilia, and he would wrap his knee against the bars and come in with a big swollen knee. And his hemophilia was a really rare form that the medicines he needed cost like $500,000 a year just for this one guy alone. And the hospital, with the DRG system, the hospital's got to eat that cost. They get their fixed amount for their stay, for what it should cost to treat a hemarthrosis in a hemophiliac. But this guy cost a lot of money. I didn't know that. I just knew him as a frequent flyer, difficult patient. And once again, I ordered him, not Suboxone, but I ordered him a PCA dilaudid pump, which means you push the button to get the patient-controlled analgesia instead of the IV push when the nurse gives it much faster. And the reason they like that fast push is because you get the rush, rapid rate of rise in the brain, in the blood and brain level, and that's what gives you that sense of well-being, that rush, that euphoria. That's the high they speak of. And when we use smaller doses on a PCA machine, you get tiny little microdoses, but you get them frequently, so if you're having pain, you can push the button, but if you get too much, you're going to fall asleep and not push the button. So that's how it's sort of a built-in safety feature. Well, what I find is the drug seekers, the true addicts, they don't like that little button. It's little amounts. That's no good. That's like being hungry on Thanksgiving and having, a pebble. It's just no good. You really want that whole freaking turkey, right? So that's the craving. And so he would say things like many people say to me, if you're not going to give it to me the right way, don't bother. Of course, they're allergic to everything besides Dilaudid. They want the Dilaudid push. I order the button, the PCA. If you're not going to give it to me the right way, don't bother. And he signed out AMA. So now the CFO is calling me to the office. Is Robert here? He doesn't remember. About 10 years ago, he calls me into the office and he says, no, not on the office, on the phone. He's like, hey, Dr. Rosenblatt, so what happened with Mr. So-and-so in the ER? I'm like, oh, hi, Mr. Bug, yeah. So I ordered the PCA pump and explained to him why it's good, and he signed out. And I thought, okay, I'm going to get in really big trouble this time. Administrators don't like when patients leave unhappy. He said, thank you. I'm like, what? He said, thank you, that guy, and he ran through the numbers on how much this guy was costing the hospital and how we all knew he was self-inflicting this. And here I was just giving good care, and he didn't like it because we wouldn't do it the way he wanted. And I think if more physicians and hospital staff and administrators would be okay with empowering our physicians and our nurses to take proper care of patients and not be bullied, not be, we are bullied. They yell at us, they scream, they threaten. I get threatened with lawsuit every day. I'm going to call the congressman, I'm going to call the CEO, I'm going to call my cousin who's a malpractice attorney. I'm like, go ahead, call. I feel strongly that I'm doing the right thing in offering you the right help. So what's happened is this hospital, our HCAP scores have really grown tremendously, our HCAP scores for pain and for many things. But that's been a process of education and empowering my colleagues and my nurses and the support of the administration who allows us to do this, to give people the care that they need, to continue to deliver the message of we're here to manage your pain and we're going to do the best we can. And as a result, the people who don't like it leave. They can give us a bad score once. If they don't come back, they can't give us a bad score again. So I think that's how it's worked in our favor for the scores. And that was an unintended consequence. I didn't see that one coming. I was very pleased with that. It's probably saved us a lot of money. It's raised our scores. But most importantly, the other day I was kind of bored. I didn't have anything to do, which almost never happens. And I went up to the 8th floor, which is our med-surg floor, which typically has the most difficult and demanding and challenging patients. And I said to the head nurse, Charmaine, did you lose my number? I'm not feeling the love anymore. What's going on? I said, we don't have any difficult patients. I'm like, that's great. You've got the pain all well managed? She's like, yes, we do. We don't have anybody on IV push Dilaudid. We don't have anybody on their call bell. We don't have anybody kicking and screaming. Thank you. And then they had, I listened, I stayed for part of their conversation that went on to say, remember the old days when we would give everybody IV Dilaudid and we gave patients whatever they wanted? And guess what? That still goes on in most places. It's just not going on here.
How many people did you see overdose on IV Dilaudid on the floors?
A gazillion, and with a needle in their arm in the bathrooms, right? We don't see.
No, the push from the nurses.
Of course, yeah, and you can just pull the Narcan data and see how many times they've given. Yeah,
Absolutely.
yeah. Well, you know, I tell my patients, and because I have the tremendous support of the hospital and my C-suite and the board, I can get away with this. I have probably 15% of the hospital patients on my census every day, so I see them and I manage the pain. But what's a challenge is one of the things I like to tell my patients is we don't give IV push Dilaudid on the floors. We just don't. It's not safe. We don't do it. It's on the button or it's not at all. And in the unit, in the ICU or in the PACU, we may, but that's a different setting. That's a more monitored setting. And it's always very hard to say that we don't do that when the roommate's getting it. So because I have so many patients, they're all mine. So you know, it's consistent, and being consistent is the most important part. Because when patients say, well, at that other hospital, they give me whatever I want, well, then go there, you know. Don't stress us all out, because it's not gonna happen. It's not safe. So yeah, lots of people overdosing on the floors at the hands of our healthcare system. The system demands it, right? The patients demand it. The night nurses call me, they want it because they want to keep their patient quiet and sleeping. It's this vicious cycle. But through educating them, and the nurses are probably my number one tool, by teaching them and by showing them the success when you manage pain properly and get some people off these high-dose, ridiculous doses of opioids. Now, I always say this at the risk of offending the, let's call them legitimate pain patients. That's what they call themselves, right? And there are legitimate pain patients. But I still feel, and I'm in the camp of, those ridiculously high doses of opiates are not appropriate for legitimate pain patients. Their lives aren't so great either. They're rotting in bed.
How many of those people beg you to get off the ridiculous, the people who are really in pain, who are on very high doses of these drugs, beg you for a way to get off? And then the challenge would be, I don't mean to interrupt your talk, will be to figure out how to control the real pain that they have without the high-dose narcotics. And that's just good doctoring if you can do it.
Yeah, I mean, and that's what I do. I have very few people come to me begging to get off, but I have had people who have gotten off say to me, I begged my doctor to take me off and they wouldn't listen. I have heard that. Yeah, I have all kinds of alternatives. I got a very deep toolbox. I do all kinds of things to manage pain, but sometimes just taking them off the opiate alone makes the pain go away. And I've had so many people, right, because I mentioned earlier opiate-induced hyperalgesia, but sometimes I love telling stories. So one of my colleagues, a big, well-renowned local physician, calls me up one day, Melanie, how you doing? Good. Thanks for seeing all my patients. You're great. Do you mind, could you see my wife? She's a pain patient, and she's been suffering in pain for years, and my partner no longer feels comfortable prescribing her opioids. And I'm like, oh, boy, this is going to be rough. Now, you know, it's going to be rough, right? This is not going to be a quick visit. So to make a long story short, I listened to her tell the whole story. He's there with his head in his hands. She's telling me how he diagnosed her. They're in their mid-60s. He diagnosed her when he was in medical school. They were married. He diagnosed her with a bunch of weird esoteric diseases that only medical students can discover, right? And she's been on pain pills.
Their spouse gets them.
Right, their spouse gets them, right. Yeah, being the spouse of a physician is a hazard. Yeah, I've been warning my fiance about that. So on lots of opioids, and his partner now decided it was, they're not registered as a pain clinic that you have to be if you're going to prescribe for more than 3 months. That was a new pill mill legislation a few years ago. So to make a long story short, I said, yes, I think I can help you, but you might not like what I have to say. And I find myself saying that a lot. So yeah, I'm going to help you, but this is what you need to do, and we're going to dial back and get you off all the opioids. And it took several months and several phone calls and several emails and several Sunday night phone calls And here's the doctor husband, well, her pulse is 110. Like, oh my God. Like, this was really a nightmare. But it was worth it at the end when they came into my office, when she's finally off of everything. She's off her benzos, she's off her opioids, and she feels great. She's out there playing with her grandkids, she's taking trips, she's on the phone, she's back, she's alive. She was downright euphoric from being off of her medicine. And they both cried to me. She's like, my family they missed me. I'm back. I didn't even know what I was missing, but here I am, I'm back, and thank you so much. And that was beautiful, yeah.
I'm just curious if you have a lot of resistance from sickle cell clients,
Of course.
because we've treated them the same way for so many years.
We've created drug addicts.
So-
Right. So the system has done this, right? I've recently become aware of the sickle cell day unit. You come in and you just get IV Dilaudid all day long. Like, what
Then
the?
they leave with their pick line, their lines, so they can have access.
OMG, yeah, it's killing me. So, but I think it's time. I treat my patients one at a time, so I'm not going to tell you globally what the answer is, right? But I think it's time that we own up and take responsibility. The system has created this, and the system can fix this. And I think if more hospitals and more physicians had the approach like we have here at North Broward, we really can get a handle on this. Now, these people, this is just a little pod of time, right? They still need to go out and have follow-up and have the proper care they need. But in the absence of an intervention, I think we're giving them medical care and we're giving them what they need, and I'm really proud of it.
You said you're using Suboxone on them. Are you seeing withdrawal from that?
Well, no. I mean, her question was, I'm using Suboxone on a lot of people. Am I seeing withdrawal from that? No, because I keep them on Suboxone because, again, a lot of these people have pain.
Doing the sub-Q implants?
I am doing this. I'm actually the first physician trained in the U.S.
Last
6 months, yeah.
6 months.
Yeah.
So that gives them a lot of time for behavioral.
Yeah, yeah. And the implant is really just a substitute for the daily dosing. It's okay. It works, yeah. I love it.
But you don't have to worry about
I love it. You can't
compliance.
shoot over it. You don't have to worry about compliance, right? I love it. But even the Suboxone, I mean, the word is you can take a whole month's worth at once and not die of respiratory depression unless you're combining with other things. So it's a little safer than methadone. So I love it. Any other questions? I can talk all day. Yes.
I just feel compelled to tell you, you kind of told a big part of my story. You know, I was in pain management. I had 2 lumbar laminectomies, first one when I was 18, second one when I was 28. And I did the pain management, did the Cadian thing, MS Cotton 100s, MSR 15s, and I hated the doctor. I would have hated you.
Yeah.
You know, I absolutely would have, but, you know, thanks to God, I'm recovering now. I don't do any of those, but I still go to pain management. I take naproxen, and I'm probably going to have a fusion.
Okay.
But, you know, those things are just not an option for me, but the technique and the way you're going about it is a big thing. Because I used to go to the emergency room all the time, and get what I wanted. And I would have my script the week before, you know. But
Yeah.
I think it's great.
Thanks.